Okay, good morning, everybody. It's 6:45, so I think we'll get going. It's my great pleasure to introduce our speakers this morning for this hot topic for our grand rounds. So I'll start by introducing Dr. Jules Vieaux, as well as Ben Arevalo, who are two of our pain specialists who actually closely follow our patients, especially here at Mission Bay and our Head and Neck Cancer Center. You might see notes from them. So this is especially topical. Dr. Vieaux is originally from New York, where he started his career in advertising and marketing. Before transitioning into medicine, he went to UC Davis for medical school, Kaiser Oakland for internal medicine residency, and then here at UCSF for fellowship in hospice and palliative medicine. Soon after, he joined the faculty as an outpatient palliative care physician. And since that time has been part of our SMS team. And as I said, takes care of a lot of our head and neck cancer patients outpatient, and we tend to then rely on his notes inpatient. Dr. Arevalo is originally worked as an autopsy coordinator here at UCSF in 2011 for the Memory and Aging Center. He then got his MD and MBA at Harvard in 2018 and went on to complete his residency in emergency medicine at the University of Chicago, where he served as chief resident. After residency, he also did the fellowship in hospice and palliative medicine here at UCSF, and he's now also on faculty here in SMS. He will be stepping away from the SMS beginning in July to complete a second fellowship in interventional pain management back in Boston at Brigham and Women's. So thank you so much for joining us this morning. We look forward to your talk.
Thank you, Galen, for the invitation to speak with the team. Thank you, Cherie, for your help with preparation and logistics. Ben and I are really excited to be here to speak with you this morning about multimodal analgesia after head and neck cancer surgery. We don't have any disclosures, but we do think it's worth taking just a minute to focus on the learning objectives we're going to talk about today because it's such an incredibly broad topic. There's three main things that we want to focus on. One is better understanding the pathophysiology of the transition from acute to chronic pain. Secondly, reviewing society guidelines that support multimodal pain management and screening for opioid use disorder risk in the perioperative period. And then finally, understanding the basics of when and how to taper opioids and other analgesia. It can be helpful to have an anchoring case study to reflect on as we go through the discussion. In this case, we wanted to focus on RB, who's a 66-year-old retired truck driver. Last year, he experienced several months of progressive dysphagia, odynophagia, weight loss, and more recently, voice changes with noisy breathing. He was seen in the emergency department, and a CT neck with contrast showed a large hypopharyngeal mass with a partial airway obstruction. Biopsy unfortunately showed squamous cell cancer. He was referred to the UCSF surgery clinic, and there he was evaluated and scheduled for a planned partial laryngopharyngectomy followed by likely chemoradiation. As we do here, during an interdisciplinary evaluation preoperatively, we got some additional history that was helpful. We elucidated that he had prior daily alcohol use for the greater majority of his life, although he'd been sober for the last 5 years. He also had a motor vehicle collision distantly and experienced chronic neck and back pain that was treated with opioids for over a decade. He had some difficulty tapering off of those as well around the same time that he was becoming sober from alcohol. And despite currently experiencing incredibly poorly controlled pain, he was still worried that even simply treating with Norco would contribute to him becoming an addict. And when we reflect on RB's situation and where we are as physicians now practicing and managing pain, especially pain related to cancer, it sets up this tension that we experience nearly daily. The vast majority of patients with head and neck cancer experience pain. A great proportion of them, better than half, experience really severe pain. We know that high pain correlates with decreased quality of life, increased risk of suicide, and lower overall survival, among many other problems that they face. Yet, one of the most powerful tools that we have to manage pain, opioid medication, carry their own risks as well. During the time that we're talking this morning, on average, 2 people will die in the United States related to opioids. And one of those 2 will have their death attributable to misuse of prescription opioid medication.
So before we talk a little bit more about how to manage pain, let's first talk a little bit about what is pain, as not all pain is the same. And here's just some useful dichotomies that I think about when I think about pain. Nociceptive pain is what we usually think of when we think of pain, whether from a laceration like that from a scalpel or bone fractures, bony mets. It produces a dull aching pain in response to prostaglandins, other inflammatory mediators that trigger nociceptive sensory neurons to fire. This is treated in the usual ways, namely Tylenol, NSAIDs, opioids. But an important second type of pain is neuropathic pain, which is triggered as a result of damage directly to these sensory neurons themselves, usually characterized as sharp shooting pain that can further cause sensitization to nerves, resulting in hyperalgesia and allodynia. And this complex type of pain requires a different approach with medications that modulate neurotransmitters, things like gabapentin, SNRIs, TCAs, and also opioids. And both of these mechanisms are at play during surgery. And in the short term, these can result in acute pain, which is a physiologic protective pain. It's usually short-lived until the damage resolves, and our goal is to reduce the intensity of pain until healing can naturally occur. However, in some circumstances, this acute pain can persist long after that initial insult and well after tissues have healed and develop into a pathologic disease state called chronic pain. And this is largely due to neural sensitization that prolongs the activation of both the nociceptive and neuropathic pathways. And it's thought that the higher intensity of pain and longer duration of pain plays a major role in the transition from acute to chronic pain. So let's just delve just a little bit deeper into the pathophysiology of the transition from acute to chronic pain. Here on the left, we have a diagram of peripheral nociceptors, and at the time of injury, the tissues and nerve endings release inflammatory mediators and neuropeptides, which will diffuse and activate adjacent uninjured nerves, sensitizing these nerves and causing structural and functional changes that leave these nerves abnormally sensitive to stimuli in a process called peripheral sensitization. And these impulses will travel up to the dorsal root ganglion, dorsal horn of the spinal cord, which serves as an interface for pain processing. And these signals will in turn ascend up the spinal cord, up to the brain, and to the brainstem, and to the somatosensory cortex, where the conscious experience of pain is generated. Interestingly, this also triggers a descending inhibitory pathway from the brain down the spinal cord to the dorsal horn to actually reduce pain and modulate pain. But with prolonged activation of these peripheral nerves, they will develop just increased excitability and spontaneous depolarization, and neuroplastic changes will take place in the peripheral nerves, in the dorsal root ganglion, in the posterior horn, as well as the brain itself, in a positive feedback loop that can perpetuate pain long after the initial insult has resolved. And the current thinking is that by interrupting the intensity and duration of pain, we can prevent the long-term neoplastic changes that influence the development of chronic pain. And this is what makes pain control in the perioperative setting so important. The incidence of chronic pain is higher in patients with intense acute post-op pain and those with greater analgesic needs in the first few days after surgery. And aside from the risk of developing chronic pain, there are many other downstream effects that are important for surgeons. Poorly controlled pain can delay wound healing. They can prolong recovery time, delay discharge, leave patients dissatisfied, and can have a whole slew of outcomes that we care about for the well-being of our patients. And as a result, these can also prolong and intensify opioid exposure, which is particularly dangerous because surgery is a juncture where chronic opioid use may begin. In this study of nearly 70,000 patients who underwent curative intent surgery for, let me just go back to the slide, 70,000 patients who underwent curative intent surgery for a wide array of cancer diagnoses, 10% of opioid naive patients continued filling prescriptions for opioids 1 year later. And these were at the same doses of those who had used chronic opioids for the last year leading up to surgery. And now none of this is meant to scare you into not prescribing opioids, as opioids do have a role for the management of perioperative pain, but there are many other levers that we can pull during this critical period to help reduce the number of patients who will continue to use opioids well after their surgery is concluded. And some of these things can be done in the pre-op period, and some will occur in the post-operative period.
Sorry for that. So acknowledging both the tension that we highlighted earlier on in the presentation, and as well the science underscoring the importance of effective perioperative pain management, society guidelines, whether they're surgical or non-surgical, national, international, reinforce a few important practices which, although not perfect, can mitigate that tension and reduce the risk for development of opioid use disorder. We'll go through these in more detail, but in essence, preoperatively setting expectations, reviewing risk and benefits of all the tools we can use, and screening for opioid use disorder risk is incredibly important. Postoperatively, developing individualized opioid-sparing multimodal pain regimen plans, assessing for pain regularly, and also planning for and educating patients on the tapering and stopping of opioids and non-opioids over time can be incredibly valuable. With regards to setting clear expectations, this is one of the most important steps that one can take early on. We realize that nearly 4 out of 5 patients report anxiety about pain before surgery. In fact, mood and anxiety, as we see on the right-hand side, may predict their experience, the intensity of the pain that they experience, even more than the type of surgery. And preoperative counseling, especially in the days in advance, as we actually do here at UCSF, as opposed to the day of, has been proven along with education to reduce patient anxiety, postoperative opioid use, and length of stay. Guidelines even go as far as to give us some specific expectations that we should review. There's 5 of them here that we want to highlight. I think first and foremost, to set the tone that we're unlikely to be able to completely relieve all pain. That pain is a natural part of the recovery and healing process. It communicates what's happening with our body, with the patient's body to us, so that we can best optimize the recovery, but yet still it's something that we won't be able to completely relieve entirely. As we do treat it, however, there's a lot of evidence supporting a variety of tools, opioids, non-opioids, and even non-pharmacologic approaches, which we will be leveraging throughout. Helping patients understand and anticipate that we're regularly assessing both their pain and the medications that we're using to treat them throughout, and that those will evolve over time as we see their symptoms change. As a part of that evolution, we would anticipate tapering opioids first, actually, as another step that can be really important, following by the non-opioids in the months after treatment. And then finally, being able to touch on the fact that mood is a really important part of the experience of pain, and that managing pain includes managing mood with both medications and non-pharmacologic approaches. It can be a helpful chance to reflect on what the side effects of opioids are, so that they, again, as we know, no medicine is perfect, and ones that we highlight particularly in palliative medicine include the main 4 of sedation, constipation, nausea, and the effects on mood that can come. Now, not all patients will experience these, and very often they can be mitigated, but at least highlighting that these will be watched for, monitored, and may be a part of our plan for actually tapering off opioids over time or rotating. Paradoxically, pain can actually increase sometimes with increases in doses of opioids. This opioid-induced hyperalgesia is something that we watch for, and we'll try to explain the hypersensitization that happens from the pain receptors that Ben was describing. Finally, many of our patients are older, and as patients age in years to their 60s, 70s, and 80s, they are at a much greater risk for any of these side effects. And then again, we'll be needed to consider how we mitigate them.
And another important aspect of the preoperative setting is to screen for opioid use disorder risk. There's a number of tools that you have at your disposal to help accomplish this. Usually these are questionnaires ranging from 7 to 24 questions, and these are out here. You can look for them if you find that this would be helpful to have some sort of structure to screening patients, but it seems not as practical to do in a busy ENT clinic with patients where time may be limited. But there are several things that we know increase people's risk for opioid use disorder that you can glean mostly from the chart or just quick questionings of patients. And this can give you just a general idea of whether somebody's higher risk for opioid use disorder or perhaps lower risk. Some of these things that are associated with this risk are opioid use more than 30 days prior to treatment. And those patients are 8 times more likely to develop chronic opioid use. Diagnosis of anxiety, depression, personality disorders are correlated, or even just the prescription of an anxiolytic like a benzodiazepine or an antipsychotic also increases the risk of prolonged use. And probably one of the most important, personal history of tobacco, alcohol, or drug abuse can be a predictor. And not mentioned here, but even a strong family history of alcohol or drug abuse can also increase this risk. So you can get a little bit of an idea just based off of a chart review or a quick review of the patient of if they have high risk factors. Let's just take this back to RB for a second. So during our preoperative setting, we counseled him on the anticipated duration and severity and persistence of pain. So he knows what to expect, hopefully reduce some of that anxiety that can increase the experience of postoperative pain. We noted that his prolonged prior opioid use, history of alcohol use disorder, and depression increases risk for opioid use disorder. And so that we'll need to be vigilant in monitoring for opioid use disorder. We developed a multimodal regimen with him, first non-opioids, but as well as opioids, knowing that we'll have to be a little bit more cautious with the prescription of opioids. We can shorten the prescribing windows to 15 days before refills with reassessments prior to renewal. And consider doing urine tox screen, checking cures database with each refill, and also connecting it with social work for additional support, additional psychosocial support, since influences on mood can also impact somebody's use of opioids. So making sure that he has good support as well as he's recovering from surgery. Now, there's a lot of levers we can pull in the post-operative period as well. Screening is important to understand the risk, but if we're able to reduce the number of opioids needed to have good pain control for patients, that's all the better. In this study, looking specifically at the use of scheduled around-the-clock doses of a multimodal regimen versus standard of care for patients undergoing head and neck free flap reconstruction, they found that 72 hours after surgery, the median number of morphine equivalents was reduced substantially in this multimodal group. This group receiving scheduled Tylenol, gabapentin, celecoxib, and as-needed Toradol and fentanyl, versus a control group of just Tylenol, Norco, morphine. They found that 72 hours of using this multimodal analgesic regimen reduced the median number of morphine equivalents from 90 in the control group to 10 in the multimodal group. And 72 hours post-operative, the multimodal group actually had a significantly lower pain score despite using significantly fewer opioids. And even more remarkable, the number of morphine equivalents that patients were discharged on were reduced substantially. In the multimodal group, dose equivalents ranging from 0 to 18, versus in the standard care group, opioid prescriptions with equivalents in the 200s to 400s. Remarkably, this was done without increasing length of stay, increasing postoperative bleeding, increasing ED visits, or even readmission after 30 days. And this isn't the only study that shows these type of findings, that multimodal regimens can reduce opioids and improve pain control and improve patient satisfaction. There are many more out there that reflect this finding. I just wanted to also just acknowledge that changing practice to use a multimodal regimen can be difficult. Some may be concerned about NSAIDs increasing bleeding risk. Others may be skeptical about the ability of non-opioid medications to really control postoperative pain. There's also just the issue of, can you make an institutional change? You can devise a pathway, but will people use it? And the authors of this study, where this graphic was pulled from, had these same concerns. They developed an optional multimodal analgesic pathway, and through the use of champions and educators, grand rounds conferences, they promoted the use of this pathway and decided to track the adherence rate of providers prescribing this over time, and if this changed opioid prescribing practices. And again, using a multimodal regimen, things like gabapentin, Tylenol, meloxicam in the pre-op setting, and scheduled Tylenol and ibuprofen in the post-operative period. We found over time, initially, providers were reluctant to use the pathway, but over time, they grew more comfortable with it, and the adoption rates increased over 2.5 years. And what they found was that there was a parallel decrease in the percentage of patients being discharged with opioid prescriptions as the multimodal regimen was used more and more. And so, multimodal regimens, they can be equally, if not better, as effective for pain control in head and neck surgery patients. This was particularly in thyroid, parathyroid surgery, but there are many avenues where this is being investigated as a helpful tool to reduce prescriptions of opioids. And now let's talk a little bit about the individual medications that were described in many of these studies.
Thanks, Ben. So as he alluded to, taking a look at some of the more recent evidence behind the 4 medications most commonly found in multimodal analgesia studies or protocols, acetaminophen, NSAIDs, and the 2 gabapentinoids, gabapentin and pregabalin. Here, patients undergoing head and neck surgery, this was a study in 2019 out of the University of Mississippi. They looked at 48 patients who received scheduled postoperative IV acetaminophen, a gram every 6 hours for a total of 4 doses, along with a standard opioid PCA, and compared them to a retrospective cohort who only received the PCA. There was notably lower opioid use, nearly half of the number of OMEs, with similar pain control in the first 8 hours after surgery, and there was a nearly 3-day shorter length of stay. We do want to point out that standard dosing for Tylenol in the longer term period, not in the peri-op, but if you're treating them for greater than 7 days as they're discharged in an ongoing period, max would typically be about 3 grams a day with normal liver function. Turning towards NSAIDs, this study looked at celecoxib. It was from 2018 out of the University of Utah, a retrospective study of patients who underwent head and neck cancer surgery with free tissue reconstruction. Sound familiar and relevant. 51 patients received celecox 200 milligrams twice a day for 5 days in the post-op period, with 51 patients who did not. There was, again, nearly half the amount of opioid use, 55 OME versus 26.9, and no increased rate of pre-flap complications. A couple of things to call out in the more practical sense. Ibuprofen may be a more common NSAID that we use in the outpatient setting particularly, although max is 2.4 grams per day. 2 dosing parameters to consider is that max analgesic effect actually occurs at 400 milligrams with maximum anti-inflammatory effect at 600 milligrams, both of which can be factored in to help mitigate concerns about cardiac and renal effects of the medications as well. This for us was one of the more interesting studies that we found, which took a look closely at dosing and different combination of medicines and the number needed to achieve greater than 50% pain relief. Looking at Tylenol, lower doses in the 650 milligram range had a number needed to treat of 4.6 to achieve greater than 50% pain relief. Simply increasing that to a more standard 1,000 milligram dose dropped it by 1 to 3.6. Ibuprofen's 400 milligram dose had an even lower at 2.5 number needed to treat. But when you start to pair them together, the combination of ibuprofen and acetaminophen was actually had a lower number needed to treat than either ibuprofen and oxycodone or Tylenol and oxycodone. Reinforcing again the idea that the combination and staggered dosing in the post-op and outpatient setting can be an incredibly powerful analgesic plan. Moving to the gabapentinoids, looking closely at gabapentin here in patients undergoing head and neck mucosal surgery. This was from 2018 at Washington University. 110 patients were randomized to receive gabapentin 300 milligrams starting in the hours preoperatively through for a total of 72 hours post-op. And their experience was compared with patients receiving a placebo. There were clinically important reductions in pain with no change in their opioid use. Here again, I think gabapentin is an imperfect medication because it does come with renal limitations and as well some of the sedating and cognitive effects. But Using it practically is a low dose to start, 100 milligrams to 300 milligrams daily to 3 times a day, increasing on response and tolerance to typically at least 600 milligrams and frequently to a maximum of 1200 milligrams 3 times a day is another adjunct that can be helpful. This was an interesting broad-reaching study that didn't focus only on gabapentin, but also methadone and fentanyl. Not for patients undergoing surgery, but rather chemoradiation for head and neck squamous cell cancer. So a slightly different population, but still interesting to see that of 60 patients with head and neck cancer undergoing chemoradiation who were randomized to receive prophylactically high, that's 2,700 milligrams daily of gabapentin compared to lower dose, probably 300 milligrams TID. Those that were in the high dose arm were 6 times more likely not to require an opioid during their treatment compared to those in the low dose arm. Finally, Lyrica, or pregabalin, was studied back in 2020, I believe, from a group in China. And this was, again, not surgery patients, but patients who were with head and neck cancer who were experiencing radiation-induced neuropathic pain. 128 patients were randomized to pregabalin versus placebo, and the pregabalin arm had improved pain control, mood, and quality of life. Notably, nearly 60% of those receiving pregabalin reported a significant, at least 30% reduction in their pain compared to 1/3 in the placebo group. Lyrica is typically dosed at low doses early, again, 50 to 150 milligrams a day in 2 to 3 divided doses, with comparable increases on a weekly basis, usually targeting at least 300 milligrams a day, perhaps up to 600 in 2 to 3 divided doses. Sharing another medicine that we use commonly in palliative medicine, without some of the specific studies for pain relief, but acknowledging that duloxetine has a terrific amount of evidence supporting treatment of mood, depression, and anxiety, chemotherapy-induced peripheral neuropathy, diabetic neuropathy, fibromyalgia, and chronic pain. The hypothesis is that increased norepinephrine is thought to help the neuropathy, often pretty early in the course, whereas typically it can take up to 6 to 8 weeks for effects on mood. Pain relief can come within 2. Start at a low dose of 30 milligrams, and you can usually titrate up pretty quickly to 60 milligrams within a week or 2. A minority of patients, 1 in 10, may experience anorexia or fatigue or dry mouth. Unfortunately, it was one of our favorite medications, because, especially for patients who had a PEG tube, because there was a sprinkles formulation that was very practical. Unfortunately, that's been on hold since about August, and there's concerns that it may not be coming back on the market. Finally, moving past all the pharmacotherapy, opioid and non-opioid, important to recognize too, integrative therapies may have a role. First and foremost, patients are using them. They're used by up to half of cancer patients, and considering that we practice in the Northern California area, probably even more of ours. Mind-body techniques, including yoga, meditation, chiropractic manipulation, and compression devices have been studied. Notably, the best evidence and most consistent evidence is for acupuncture, actually, both in the acute and chronic setting of managing pain. These studies here highlight a range of benefits: pain for patients post cancer, head and neck cancer surgery, and as well, xerostomia has some evidence behind it. And I think there's a much broader range that would be worthy of a much longer, deeper discussion. Finally, reflecting on the society guidelines, the 5th of the 6 guidelines that we highlighted earlier was conducting regular pain assessment. Similar to screening for opioid use disorder, there's an incredible constellation of tools. And the fact of the matter is, none of them are universally applicable. If there's a couple of pearls that we would share in terms of how to practically approach a pain assessment in clinic postoperatively, first and foremost, focusing on function has an incredibly important role, and in some ways can be more valuable even than the scale of 1 to 10. It really starts to set up milestones that can be focused on and used as benchmarks for evaluating success of any plan. And as well, screening for mood and the effects of pain on it, depression, anxiety, even suicidal ideation. Finally, recommending a symptom journal for patients is another important tool that we use in palliative medicine regularly. What you're going to see here on these next 3 slides are 3 real symptom journals that were kept by patients tracking medications over time and effects on their symptoms. When we're in clinic, we typically focus on trying to understand what's been happening really specifically over the last 3 days, asking them to describe their pain with an understanding of whether it's sharp, dull, achy, radiating, because that can then point us towards the distinction between nociceptive versus neuropathic versus others and help guide treatment. Again, focusing on function, what are you not able to do because of the pain? Is it interfering with eating, with talking, with sleeping? Can help us create new milestones that can be even more valuable than simply getting to a certain pain level. And then finally, getting really specific with the medications they take. When did they take them? What dose were they taking? How did their pain and function change in the period afterwards? I just do want to call out, sometimes when you give patients guidelines to create symptom journals, they can really go pretty far. This was one of my favorite patients who actually translated each of her pain scales into a translation of what it was affecting in terms of her function. It really helped us guide treatment throughout and make modest changes that were really effective in helping optimize her function.
All right, so let's say RB, or a patient from the beginning, shows up to clinic, says the meds just aren't working anymore, doc. They notice that his use of opioids have increased. What does this mean? Would a patient request more pain meds? I'm sure a number of things may go through your mind, like these listed here. And it really just depends on what RB means by the meds aren't working anymore. Is it that he's requiring a higher dose than before to control his pain because he's developed a tolerance to the pain medications? This is less likely unless he's been on opioids over an extended period of time, but always something to consider. Is his pain actually well controlled with the medication, but if he misses a dose or two, he begins to experience anxiety, insomnia, nausea, or some withdrawal symptoms, and has developed a physical dependence on the medications, and that's what he's interpreting as not working. A quick note here, dependence does not mean somebody has an addiction, but it's really just a physiologic adaptation to prolonged use of opioid. Or are they not working by causing him to have new cravings that he didn't have before, compulsive use, or having disruptions in certain social spheres of his life, and might be signaling an early addiction? Or could these problems represent what we call a pseudo-addiction, which is when we as providers mistakenly assume that a patient is requesting more pain meds due to an addiction, when in fact, they're really just asking, frankly, for better pain relief. It's important to make sure that we're not withholding medications from people who can benefit, but also being cognizant of these other aspects of chronic opioid use therapies. In terms of what we do to help address, he very well may need increased doses of opioids. However, first take a step back, reassess the multimodal regimen, and see, has he been scheduling the medications around the clock? Even when pain is minimal, still scheduling those pain medications can be a great help. And the studies bear this out as well. Is he missing doses? We just need to set up a system for him to take the medications consistently. Has the regimen been maximized? Have we reached the kind of daily limit of Tylenol or ibuprofen or even gabapentin? Or is he having comorbid mood symptoms that are really interfering with his pain management? And if this increase in mood symptoms may worsen pain, and if that is the underlying cause, that is unlikely to be responsive to opioids or the other medications, and getting further support with social work or SMS, or even starting an SNRI like duloxetine mentioned earlier, might help better target pain and mood issues. But now let's talk about reasons to discontinue opioids. Once you've met your agreed upon goals and timing that you set out in the preoperative setting when you were setting expectations, if you've met your agreed upon goals or agreed upon timing for prescribing the medications, then great. It's a good time to discontinue opioids. If the patient's having unmanageable side effects like those that Jules had mentioned previously, and is creating different issues that are burdensome to the patient, things like nausea, constipation, mood changes, be a good time to discontinue opioids. you're not meeting those pain goals, or they're not having an increase in their function, even with increased upward titration, or if they're getting less than 30% improvement in pain and function, the opioids are likely not doing their job and fulfilling their role in this multimodal regimen, in which case it would be a good time to discontinue. And of course, if there's any concerns of non-adherence to the treatment plan, they have concerning use or concerns for diversion, this would be an impetus to evaluate for opioid use disorder. And in this situation, refer out to help, either your colleagues in SMS, addiction medicine, psychiatry. These situations can be quite tricky, and so referring out to help in these situations was likely to be beneficial. And it's important how we talk to patients about discontinuing opioids. It might be tempting to just use the opioid crisis as an impetus to decrease opioids, or shift blame elsewhere in the system broadly by saying things on the right, like guidelines won't let me prescribe, or I'm not allowed to prescribe at these doses or this far out of surgery. And I would discourage you from using the type of phrasing that really shifts the blame and shifts the concentration elsewhere. Really, it's better to center discussions on health concerns of the patient so that they know that what you're doing is really in their best interest. So using phrases instead like, we are not achieving the goals that we targeted initially, so we should discontinue these. I believe that the opioids may be increasing your pain, and I think it might get better if we decrease the medications. And this is true, especially in the case of opioid-induced hyperalgesia. We find that decreasing pain meds in chronic pain actually doesn't make pain worse and can often make it better. Or just point to specific examples like we discussed earlier. I believe it'd be better for you to discontinue because you've been having these issues with falls or nausea, mood changes, and that getting off the medications would be helpful. Now, how do we actually taper these medications? Well, first step would be to optimize non-opioid pain management strategies first, with the plan to taper the opioids and then followed by the non-opioids. And just as you agreed on a plan to start the medications, you also need to agree on a plan to stop. So no surprises, no abrupt unilateral tapers unless you have concerns about patient safety. And make sure that it's predictable for you and the patient. I'll often give patients a timeline in their after visit summary so we both have a good roadmap of what to expect over the ensuing weeks. And in terms of the actual practical matter of tapering, there are no studies that show that one tapering strategy is better than another, and largely tapering recommendations are expert opinion. What I've aggregated here is generally in line with practices that people use. Basically, it's the longer somebody's been on these opioids, the longer you need to take to wean them off. If they've been taking opioids daily for months to years, then you'll want to target a 10 to 20% reduction of their starting total daily dose, reducing it by that 10 to 20% of that amount every month. If they've been taking it for a shorter period of time, so if they've been taking it daily for weeks to months, you can speed that taper up, do 10 to 20% reduction every week. They're only using the medications on an as-needed basis, usually less than daily. There's no taper needed. You're pretty much done. The patient basically has self-tapered themselves, and you can stop the medications. But if you have concerns about misuse or diversion with patients, this situation can be quite complex in ensuring patient safety while tapering these opioids, in which case this would be a situation where you refer out to help. Again, your SMS colleagues are always happy to help with these very complex situations. And the reason that we reduce opioids by this 10 to 20% and over weeks, potentially months, is to minimize opioid withdrawal symptoms. And again, opioid withdrawal is due to physical dependence, but that does not mean that they've developed an addiction or opioid use disorder. And our goal is to minimize these symptoms, reassuring patients that if they do have withdrawal symptoms, that you'll be able to control them with very readily available medications that you can prescribe patients to help them deal with these symptoms. Most common symptoms are things like anxiety and insomnia. They also might get autonomic symptoms, cold sweats, chills, feeling jittery, or nausea, vomiting, diarrhea, muscle aches. These are all things that you can treat and can treat quite well. So in the instance of autonomic symptoms, clonidine is frequently prescribed. Tizanidine is actually a great medication for these as well. For insomnia or anxiety, you could prescribe hydroxyzine. You could prescribe trazodone if insomnia is quite bad, Zofran, Compazine for nausea, loperamide for diarrhea. Control the symptoms, reassure the patient that these are temporary, these will get better over the ensuing days. And if they do experience withdrawal symptoms, pause your taper until the withdrawal symptoms have abated, and then slow the rate of taper over time. But don't take a step back, continue to taper just at a slower rate. And if symptoms are quite bad with the withdrawal symptoms, again, with the 10 to 20%, it's unlikely, but in the case that it happens and you're really running into a wall, again, it's always okay to ask your SMS colleagues for help. In the interest of time, I think we'll just also thank some very important people who had input to our presentation here, who are listed here. And so we're going to express our utmost gratitude for them helping us make sure that the talk was as accurate and relevant as possible. And I think we've left a few minutes for questions.
Hi, I have a question. So I'm Chris. I'm with the head and neck team here at Mission Bay. We often send people out in the perioperative period with gabapentin, and just sort of that, I noticed that you said that opioid patients in short-term use, they can just sort of DC themselves. Do you recommend tapering them off of the gabapentin, or can they just like stop it when they feel better?
I'll let Ben weigh in as well if his practice. I would prefer to have them communicate with me and do a slower taper over some period of time, at least like 2 weeks or so. I think you'll see greater risk of especially problems with sleep and mood and anxiety if they just suddenly stop taking it, which I think more commonly can happen. They'll maybe taper over a matter of 2 to 3 days. And so just trying to drop by a couple 100 milligrams a day over weeks is probably going to be a more effective strategy in the long run.
Yeah, and I find it tends to be more important in higher doses. Patients taking 1200 TID, 900 TID. If someone's just been on 300 TID, I'm a little less worried about discontinuing rapidly. Generally, my practice is the same as titrating up. Generally, I'll do increase by 300 milligrams every 3 days. Just kind of keep it simple, this rule of threes. And same thing with discontinuing, or at least reducing total daily dose by 300 milligrams every 3 days. It's usually a slow enough taper in terms of ramping up and ramping down that really minimizes a lot of those symptoms. But I don't think there's perfect guidance on the right way to do things, but I think that rule of threes is generally pretty well used in clinical practice.
Okay, and then, sorry, everyone, just one more question. Patients that come to us with a lot of anxiety, you mentioned starting them on duloxetine. I know that we try to mitigate the use of benzodiazepines while they're in the perioperative period while on opioids. But when do you see a patient that you think like, the anxiety is feeding their high narcotic use? When do you start them on something like duloxetine, and kind of what dose do you usually start with?
So dosing would start at 30 milligrams. I have a low threshold if there's anything that we can treat that's interfering with their ability to be maintain adherence with getting surgery or the recovery or the therapies afterwards. And I think we probably underuse it more than anything. It's that combination of opioids and benzodiazepines that we know brings an incredibly high risk. And I think what's probably underutilized as well is talk therapy, right? It isn't always a medicine, and what they're going through is real. And being able to just say it out loud and find ways to process it from their strategies that they've used in the past is probably something else. Unfortunately, our referral process is such that it takes a month to 2 months to get in with psycho-oncology, but we'll often leverage the community resources as well.
Awesome, thank you.
And just to add briefly to that, gabapentin can actually be used as an anxiolytic as well. So patients, as you're up titrating that, they may get reduced anxiety with the up titration of gabapentin. And other anxiolytics that can be helpful, hydroxyzine can actually work as a anxiolytic as well. You might have that prescribed as well. So there are other pharmacologic things as well that can be useful in reducing the anxiety.
And sorry, I know we're running short on time, but maybe call out for Dennis Ho on our social work team as well. They are incredibly powerful at being able to just ask the questions about what are they anxious about, right? And being able to sometimes mitigate some of the other financial and practical aspects that could complicate the recovery.
Thank you so much. We're at 7:30, so we'll let everybody sign off. And if other people have questions, feel free to email. Thank you both so much for joining us.
Thank you for
Thanks
having
for the
us.
chance to take care.